Good evening, guys. I'm Professor Reid Ali from Baragwanath Johannesburg Hospital. Welcome to all the fellows and all the other fellows from Sub-Saharan Africa to this meeting. The presenter today is Lawrence Kwape. He's from Tygerberg University of Stellenbosch in Cape Town, and he's going to talk to us about food allergies. But before that, I'd like to say this thank yous on behalf of the Gastro Foundation, who hosts this meeting in collaboration with Project ECHO out of New Mexico and with the help from the people from India. So thanks to them. This runs every second week, but apparently Professor Sachedi is going to make an announcement at the end telling us about an extra meeting that is being held next week. So at the end, Masheko will let us know about that. Karen normally says if you guys want to ask questions, put it in the chat box. I don't know how to read that stupid stuff. So if you want to just raise your hand and ask the question, and I can interrupt or ask Lawrence, or we can try and help you. So Lawrence, thank you. Fire off. We look forward to your presentation.
Good afternoon. My name is Lawrence Kwape. I'm from Tygerberg Hospital. Thanks to Prof. Ali for his guidance on the presentation. Our today's talk will be on food allergies. Sorry, I was just having a problem with progressing. So we know that adverse food reaction is any untoward reaction that occurs following. Sorry, I'm just sorry.
Lawrence, it's okay. We can see your slides and we can see you talking. So.
All right. Yeah. So food reaction is basically an adverse reaction or any untoward reaction that occurs following ingestion of a food additive. So in terms of for food reactions, it can either be toxic, which is basically the food poisoning, where it's supposed to be a specific ingested amount versus non-toxic, which we'll expand more in the next slide. For toxic reaction, we're not gonna focus much on the toxic reaction. Is mostly for food poisoning. And then non-toxic reaction, it can either be immune mediated, which is mostly Ig mediated, and non-immune mediated, where we deal with food intolerance. So in terms of non-immune mediated, we know that we have food intolerance, which basically occurs due to several mechanisms. It can either be enzymatic. For example, in patients who develop lactose intolerance, they have a deficiency in lactase enzyme, which basically resulting in lactose intolerance. Other pharmacological, or if there's no identifiable cause, it's idiopathic. So specifically for food allergies, which are immune mediated, can either be IgE mediated or non-IgE mediated. So we don't have much in terms of numbers on our local setting, but it's proposed that around 2 to 10% of the overall US population has food allergies, with most commonly found in children. This is just to reintroduce food allergies that you mentioned, that they can either be toxic and non-toxic. And then for non-toxic food reaction, which are basically it can either be immune mediated. For immune mediated is what we previously mentioned, where it's food allergy which is either IgE mediated or non-IgE mediated. We will expand more in terms of IgE mediated, but for non-IgE mediated, some of the examples are food protein-induced enteropathy. So it can also be non-immune mediated. Example is food intolerance, which we mentioned in the earlier slide. Most commonly we see for enzymatic lactose intolerance, or we can have a reaction to like food additives, amines, or undefined, where things like IBS fit there. This slide is basically to say that we tend to get food allergies when we are young, but as we grow older, as we each decade we grow older, they say that we become tolerant to different foods, as we can see examples there. But of note, I want to point out that peanuts, which basically are considered as legumes, in specific percentage of individuals, we find that they don't outgrow or don't become tolerant to peanuts. So we tend to find that peanuts in adults can persist from children in terms of adults still having allergy to peanuts. So that's very important point to note. In terms of for food allergies, we should note that each and every individual, in terms of our GI tract, as we eat food, for the food is for us to utilize it in terms of for energy and dietary and nutrition. It happens that as we eat food, food particles, the GI is quite an intact barrier that protects us from food particles reaching reaching our systemic circulation. This is not just food particles, virus, bacterial, reaching our systemic circulation, but it happens that in individuals, some individuals, food protein or particles, they penetrate this barrier, natural barrier that will expand here and reach systemic circulation with no like sensitization or any allergy or reaction, but in individuals, other individuals, they react to that. So what are the barriers that we are talking about here? We have physiological barriers, which basically here they block penetration of ingested antigens. This basically include epithelial cells, plaque or calyx, interstitial macrovillus structure, which and also this epithelial cells have tight junction in between, which basically helps in terms of blocking antigens from penetrating through the GI. Also, interstitial peristalsis is very important in preventing or peristalsis movement of these particles and preventing them from penetrating the GI tract. There are other categories that we should be aware of, that in each and throughout the GI tract from the mouth down, there are several enzymes involved, which are involved in breakdown of ingested antigens. Thus, all this, they prevent penetration of unwanted antigens into us. So we have salivary amylase, gastric acid pepsin, pancreatic enzyme, and interstitial enzyme, and interstitial cell lysosome, all listed here. Apart from physiological, we have immunological, which basically here are involved in also blocking ingested antigens, mainly due to antigen-specific immunoglobulin IgA mediated in the interstitial lumen. So all this involved in clearing the antigens from penetrating the systemic circulation. Also, the other important aspect that we should be aware of, reticuloendothelial system. We know that the GI tract It's gastric associated lymphoid tissue is quite rich in terms of the lymphoid. So all this are involved in protecting us from ingested antigens. And also it's very important to know that each and every individual has many layers and layers of different microorganisms, microbiota, which are basically each and every individual, they are involved in maintaining the integrity of GI and mucosal layer. Thus, all this working together is involved in protecting us from unwanted antigens reaching the systemic circulation. This is just to remind us that hypersensitivity reactions can be classified into type 1 up to type 4. But mostly here, it's be focused into IgE mediated, which basically occur within 1 hour of ingestion of antigen. We'll expand more into the next slide on IgE mediated hypersensitivity. Others types is just for us to be aware. Type 2, which is Ig or IgM, mainly cytotoxic cells. It's more prolonged, hours to days, and involves like hemolytic anemia. And then type 3, complement activation, immune complex mediated, more 1 to 3 weeks. Example here, things like SLE, and type 4, which is more delayed, like days to weeks. It's a T cell mediated. These examples here, we have like Steven Johnson. This is just to say that in an individual for IgE mediated food allergy, we have here is just to illustrate that a low dose of peanuts, skin contact, if it doesn't get digested, you get intact peanut protein. Penetrating, like we mentioned, the GI barrier. So within systemic lymphatic circulation, it activates both cellular mediated. As we can see, the cascade here, it's mostly interleukins, mostly with interleukin 13-6, and all this with final activation of B cells and producing IgE. So what happens here is that the individuals become sensitized such that the time they eat peanuts, there is activation of mast cells. So this mast cells release histamine, leukotrienes, cytokines, and prostaglandins, which are basically involved in systemic presentation of individuals. So these are some of the symptoms that the individual will present with like airway obstruction, arrhythmia, as well as hypertension, and local GI symptoms, cramping, diarrhea, itching, nausea, swelling, and vomiting. So for IgE or food allergy, as we categorized it as IgE mediated, versus a mixture of IgE and non-IgE mediated and non-IgE mediated. So they are classified in different clinical syndromes. So IgE mediated, mostly we have oral allergy, or is mostly just localized or oral oropharynx, where patient will just have oral peritonitis plus or minus angioedema, and significant itching within the oropharyngeal. And then the other one that we should be aware of is gastrointestinal immediate hypersensitivity, where it's immediately upon like ingestion of food, patient will present on with GI symptoms, mostly nausea, vomiting, pain, and diarrhea. So we're not gonna touch more into like mixed IgE and non-IgE, where it's mostly eosinophilic esophagitis, eosinophilic gastroenteritis, with different presentation. As we know that for eosinophilic esophagitis, mostly they will present with like a bolus food, saying it got stuck, more like dysphagia. And they can also have a mixture where IG, non-IG, eosinophilic gastroenteritis, which present with stated GI, vomiting, abdominal pain, diarrhea. And most importantly, these individuals, especially kids before reaching adolescence, puberty, they'll present with like failure to thrive. The other entity that we should be aware of, non-IG mediated, the group here is mostly food protein-induced enterocolitis. We have food protein-induced enteropathy, protein-induced proctocolitis, and celiac disease. We'll expand more into this more specifically like celiac disease, but we should just be aware that you can have IG mediated mixture and non-IG mediated. So when we get a patient which we suspect that they have a food allergy, so the most important is the history. So what food the patient takes, and what food, what symptoms the patient present with, specifically specifying specific food that triggers the adverse food reaction. So after possibly identifying that indeed there are possible foods that trigger this food allergy or food reaction, we go back to our classification where we say it can be non-toxic, toxic. If it's toxic, then we should educate the patient. And specifically for non-toxic, which mentioned is either food intolerance or food hypersensitivity. For if we suspect IgE mediated versus non-IgE mediated. For non-IgE mediated, as you mentioned, one of the examples is celiac. We can do laboratory tests to try to identify and diagnose the diagnosis of celiac disease. But if you suspect IgE mediated, screen test is indicated. But this one specifically, you have to identify the food that the patient react to. So if the skin prick is positive, specifically you ask about any history of anaphylaxis. If yes, you should restrict the food. But if no, or if it's suggestive, you eliminate the diet. But if symptoms persist on eliminating the diet, then it's important to look for other causes, as we will probably expand more in terms of other possible etiology that can present as a food allergy. But with that eliminating, if symptoms improve, we must resume the regular diet, and no symptoms occur, continue the regular diet, and then symptoms recur, eliminate food from the diet. So this is basically trying to eliminate the diet that brings up symptoms and trying to restrict or stay away from food that you think bring symptoms. But if skin prick is negative, we just consider an observed oral food allergy. If history is strongly suggestive, or is not consistent IG-mediated food allergy, reintroduce food into the diet, but take specifically is to avoid the food that triggers the allergy. So this is basically just say eliminate food from the diet, and you have to make a list of the food that provoke the symptoms, and then try to restrict the food. Yeah. So this is just a brief on food allergy, but now we're going to be moving into lactose intolerance. So you know that lactose is a disaccharide, which is a beta D galactose plus a beta D glucose, which are under beta 1,4 linkage. It is, you know, that it's digested by enzyme lactase in the brush border of intestine. So when we develop lactose intolerance, it's inability to metabolize lactose. So it can either be congenital, where we have complete deficiency or complete absence of lactase enzyme, or possibly primary or secondary. So in this individual, for some individuals where they initially they will probably does not have lactose intolerance, but as they progress or as they grow old, due to several factors, for example, surgery, celiac and other illness, they develop lactose intolerance. So this is briefly just to say lactose. We need lactase, as in glucose and galactose. Glucose, which is very important in terms of our energy production. So this slide is basically to say that when lactose is not digested or is not broken down by lactase, and within the bowel, we have lactic producing bacteria, which produce beta-galactosidase, which basically break down lactose into galactose and glucose. And then with galactose and glucose within the GI tract, they get fermented, producing hydrogen carbon dioxide. So carbon dioxide is what basically causes patients to come with abdominal pain, bloating. And it happened that in individuals, they have some bacteria which further act on carbon dioxide, resulting in methane. So we'll find that some individuals, they will present with constipation, mainly due to like a methane. I think of note, we should also just be aware that lactates fermented will result in short chain fatty acid as the end products. Other important thing is for patients, as the lactase reach the GI tract within the bowel lumen, because of its osmotic nature, it pulls water into the GI tract. So this is what result in shortened transit time and patient presenting with diarrhea, in addition to other symptoms of lactose intolerance. In terms of clinical presentation, as we see from the slide here, majority of patients will come with abdominal pain, gut distension, flatulence, borygma, and then the other ones, as indicated here, will come with diarrhea, vomiting, and nausea. So in terms of diagnosing lactose intolerance, several tests we can do, but mostly we use lactose intolerance hydrogen breath test, where individual, its breath test is tested for hydrogen from 3 to 6 hours. So the positivity of this test increases as the hours as the hours of measuring like hydrogen gas production increases up to 6 hours. So the idea is we compare with the normal, as we can see on the red line here. For individual with the lactose intolerance, they tend to have more than 20. If they have more than 20 above the baseline, that's 20 ppm hydrogen, that's what they move. Then we say that positive for lactose intolerance. This is just a brief on lactose intolerance. We know that for patients with lactose intolerance, the main management is dietary management, where as we can see on the slide here, we should try to avoid food, milk containing butter, milk, coffee creamer, cream cheese, milk chocolate. All this can result in lactose intolerance and symptoms. But the other important thing is for patients, not all patients with lactose intolerance will present with symptoms of lactose intolerance. So this dietary management should be individualized to each and every patient, because completely avoiding these products, patient can present with complications, vitamin D, osteopenia, osteoporosis. So it should be tailored to each and every patient. The other, which is not can be used, is lactase enzyme supplementation therapy. Yeah. So due to time,
Lawrence, sorry. Yeah, can I just ask, stop there now? I think that was an excellent overview. I like your slides. Is there anybody who wants to ask anything about food intolerances and lactose intolerance before we move on to specific celiac disease? Just show us your hand, or if you don't want to type. While we're waiting, Lawrence, what do you give in the hydrogen breath test? What do you give the patient?
For hydrogen?
Yes. Before we measure his breath, what do we give him?
It's more like a radio labeled, yeah. So which will allow us to measure the produced.
That's for Helicobacter. So all you're doing is here, you're giving a high dose of lactose, yes? So as the patient maldigests the lactose, it gets delivered into his colon where it gets fermented, then you release the hydrogen. So you're giving lactose high doses. You can also do a glucose blood test. So after you're giving him lactose, you can measure the glucose, and if he's got lactase, the serum glucose goes up. But what we often do is a hydrogen breath, but you're giving lactose high levels of it orally.
Okay. Thanks, Prof.
Any other questions for anybody? I think food allergies is an important point. You raised it. I think pediatrics sees it a little bit more often, but very often it would come to adults. We should just be aware about it. And I like the way you classified it. All right, nobody seems to want to ask any questions. So let's go on, Lawrence, to the second part.
The second part is gluten-related disorders. So in terms of gluten-related disorder classification for their pathogenesis, it's quite broad. We have autoimmune, which for autoimmune, under autoimmune, we have celiac, gluten ataxia, and dermatitis herpetiformis. And then still under gluten-related, you can have allergic, most commonly wheat allergy. So under wheat allergy, you can have respiratory allergy, food allergy, and with DS, I'll show this one, and then the other one is contact urticaria. But our focus won't be on wheat allergy, and then the other one with not autoimmune or not allergic. This more innate immunity, gluten sensitivity, which is more where we talk about non-celiac gluten sensitivity. So I think I will touch on celiac disease because of time and because celiac disease is quite a broad topic. So this is just to point us, and then if anything that can be raised, we can discuss. So you know that celiac disease, it's multifactorial in terms of etiology in individual with exposed antigen, appropriate antigen, which here is gluten, more cladding protein with appropriate genetic predisposition where they have haflotide DQ28. We'll explain, we'll talk more on that. So those are the individuals who, because of their immune susceptibility, then they tend to develop an innate and cell-mediated response. All this cascade result in destruction of intestinal villi. So it's basically a chronic autoimmune disease of the small intestine triggered by this ingestion of gluten, and causes interstitial inflammation and impairs with damage of villi and intestinal microvilli. Then there is impaired absorption of nutrients. So this patient will present with multiple nutrient deficiencies. And then, as celiac disease is multisystemic, it has various complications, most commonly osteopenia, osteoporosis. And you should just be aware that for celiac disease, if untreated, present with complications, most likely for that untreated celiac disease, they can progress to lymphoma, non-Hodgkin, and then even small intestinal adenocarcinoma. So for celiac disease, in terms of the pathophysiology, I think we touched on pathophysiology, that in an individual who's genetically susceptible with haflotide GLADQ28, you expose them to gliadin, which is basically a non-soluble protein. So it's cascade or activate both innate and cell-mediated immunity. So here we see that there is helper T cell and antigen presenting cell within the complex gliadin with HLA-DQ2. So all this will activate antibodies, mostly anti-TTG and plasma cells with release of cytokines or interleukin-4, tumor necrosis factor. All this contribute to damage of enterocyte, and resulting in complication of celiac disease. Is quite pathogenesis is quite complex. So an individual who present with celiac disease, because we mentioned that it causes loss of villi. So because as we can see on the slide here, for patient with normal healthy mucosa, they have a long villi and short crypts. But so we classify the progression of celiac disease in the GI tract by MASH classification. So you can see in MASH 0 here, we have a healthy mucosa, long villi, short crypts. But MASH 1, where we have basically, as you can see on the arrow there, is increase in immune cells, interstitial immune lymphocytes increase within the epithelial. So we see that in terms of the villi, they are still long, and then the crypts, they are still short. But as we progress to MASH 2, we develop more elongated crypts. We see that there's shortening of the villi, and as they progress, we have shortened villi, crypts progress. MASH 3A, B, C, up to MASH, I don't know, where we have complete, let's say MASH 4, where there's complete loss of GI mucosa. So we should know that for villus height to crypt depth, it's 4:1. So in patient with celiac disease, we tend to lose this ratio where we have shortened villi. So they lose this ratio of 4:1. I think because of this tedious classification to inter-observer difference, some can use QMASH. One go more into QMASH classification. For celiac disease in breath, you have to have clinical suspicion. We go more into clinical presentation, serology, and then biopsy, and then you go into like a therapeutic response. In terms of clinical suspicion, patient with celiac, I think they used to say can have classical, non-classical presentation. So we can just have GI presentation or extra intestinal manifestation, which could be systemic, multi-systemic. Almost each and every organ is affected. This list is just a few list of presentation of celiac disease. Can be symptomatic, as in classical. You can have a classical presentation where it's not symptomatic or asymptomatic. Or we can have somebody going towards celiac, no symptom at all, but they are genetically predisposed to develop a celiac. Or in patient which we diagnose the celiac disease, it can have a varied presentation, non-responsive up to like a refractory celiac. But most presentation here, we have the bloating, gas, abdominal pain, diarrhea, constipation, pale, foul-smelling stools. They can get weight loss, which is very important. The other thing is that they can have extra GI manifestation where it's just present with arthritis, osteopenia, osteoporosis, change in mood, depression, irritability. Just a patient with the celiac, they can just present with anemia, where they just have extreme fatigue, also with anemia, just as a presentation, menstrual irregularity, dysfunction in excess of the pituitary, so it's an infertility. They can just present with oral abscess ulcers, tooth discoloration, or dermatological presentation. It's quite a long list in terms of the presentation of celiac disease. So for serological markers, recommended first-line screening test, we have to do IgA anti-TTG antibodies and IgA, and then the other, I think IgA levels are important. In somebody with IgA deficiency, the other useful title that we can do here is IgG anti-TTG antibodies, and then other useful tests that we can do, it's IgA anti-endomysial antibodies, IgA DGP. We don't do haplotype or genetic testing, but it's high negative predictive value. The patient comes positive HLA-DQ2, DQ8. So these are useful tests that we can do, but we suspect celiac. So this is just in terms of endoscopic evaluation. We can see at A, there is quite the ratio that we talked about, where they get high villi, like 4:1 to crypt ratio at C, and the C now, where patient with celiac disease, they have loss of villi with what we call scalloping. So this classically on endoscopy, this is what we will see. But histology, we can see under D that there's quite a loss of villi there. For patients with villus atrophy, we should have differentials that we think of. Most commonly, TB should be on our list, and even interstitial lymphoma, and IBD, most likely Crohn's. So in terms of management, how we manage, it's a multidisciplinary approach. It's a dietitian. It's very important, as they are important in terms of explaining to the patient which food are gluten diet, which one is gluten-free diet, and really educating the patient as they will need lifelong adherence to gluten-free diet to avoid a complication. As you mentioned, identification of nutritional deficiency, we can develop vitamin D, vitamin, even up to like K, because of malabsorption nature. So we should be able to identify present deficiency and address them appropriately. I think for patients, they should have groups that will help them and really help them to go through and adhere to gluten-free diet. And they really need a continuous long follow-up by this team to ensure a really good response. So clinical response, when you take a gluten-free diet, is immediate, but it takes weeks to months to get a serological response, and mucosal healing quite takes long in this patient, but we'll see that with patient with villi atrophy, they return back to normal. A patient who we give gluten-free diets, we have poor response to gluten-free diet. That's when we talk about non-responsive celiac disease. Patient who can also progress to like a refractory to celiac. Even when we give them gluten-free diet with appropriate multidisciplinary approach, they still don't respond within, like, it should take up to 6 to 12 months to say that the patient are not responding. This was just a brief overview of celiac. It's quite a big topic, but this just pointers. The other entity that we should be aware of is non-celiac gluten sensitivity. So it's defined as we give patient gluten diet, no symptoms. And then you test for celiac-specific antibodies, they are negative. Absence of celiac-specific histology. And then for HLA status, they are quite variable, and it's quite resolution of symptoms on gluten withdrawal. So this can be quite challenging sometimes with patients with non-celiac gluten sensitivity, celiac. If they stop gluten without doing specific antibodies, it's difficult to differentiate between non-celiac gluten sensitivity from celiac. So the prevalence is quite varied. It's unknown, but it's quite a range, 0.6 to 13%. It's more in adults, more females, male to female ratio. It's 1:2.5. Symptoms are quite wide, multisystemic. Can have GI symptoms as indicated here, abdominal pain, bloating, diarrhea. Same symptoms as celiac with classical. It's very difficult to differentiate the symptoms of non-celiac gluten sensitivity from celiac, and also it's quite multisystemic. So this, with this, it's gluten-related diseases with their non-specific presentation, because they can present similar way as IBD, Crohn's, and IBS. So it's always a challenge to say, does this patient has probably diarrhea predominant IBS versus Crohn's versus gluten-related diseases. So it will require extensive history, workup, but even after that, it's quite difficult to differentiate, because you see all of them come with nausea, constipation, abdominal pain, alternating bowel habits, and diarrhea. So the pathogenesis of celiac, non-celiac gluten hypersensitivity is quite complex and is unknown. It's studied. It has not been studied a lot. So they say it's more like receptor key role. Mostly innate immunity is upregulated, and then there's expression of Claudin-4, which basically decrease interstitial permeability. So in here, it's like more predisposed to malabsorption. So amylase trypsin inhibitor and FODMAP diet are all like risk factors that have been identified to contribute to pathogenesis of celiac gluten hypersensitivity. So it's primarily a diagnosis of exclusion. You should exclude celiac disease by histology, serology, but not mostly HLE. With allergy excluded, you have to measure IgE levels, eliminate gluten. We'll go more in terms of its diagnostic criteria. So the criteria to diagnose it, it's mostly to look for clinical response to gluten-free diet. So, and then from there, you measure effect of reintroduction. So there is a score or a questionnaire that we basically use on a weekly basis, which patient that we want to rule out celiac gluten sensitivity, and then they mark this questionnaire. I think, as we can see here, that if you want to really exclude a patient non-celiac gluten sensitivity, the patient needs to be baseline on a gluten-containing diet, gluten-containing diet. And then from there, they have to be on gluten-free diet for 6 weeks. So after 6 weeks, you have to assess by the questionnaire, comparing with the baseline, have they improved, have they not improved? If they have improved, then there is a likelihood of non-celiac gluten sensitivity, which will do some further introduction of gluten. But if it's not improved, as we see on this slide, then non-celiac gluten sensitivity is excluded. So for a patient who improve on 6 weeks of gluten-free diet, week 1, you have to introduce a gluten-free diet plus gluten. That's just a gluten, and the other one is just a placebo. So first week, daily assessment with the questionnaire, we have to assess, is there more than 30 points increase from the baseline? So, and then week 2, you have to give them a break where you give them gluten-free diet, and you assess them daily with the questionnaire, and you reintroduce gluten. But if patient develops symptoms, and then they will measure their questionnaire or a scale, if it's more than 30 points above the baseline, then you suspect that they have non-celiac gluten sensitivity. It's quite difficult to diagnose, but these are the steps that we probably just follow. So this is just a comparison for celiac disease, non-celiac gluten sensitivity versus wheat allergy. For prevalence for non-celiac gluten sensitivity, it's quite a small population studies, so the prevalence is quite difficult. So for celiac, it's autoimmune, and then non-celiac, non-specific immune response, and with allergy, IgE response, and genetics. HLA DQ2, DQ8 haplotypes positive in 95% for celiac, and then around 50% of non-celiac gluten sensitivity will be positive for DQ8, and for wheat allergies negative. And for serological markers, mainly that's what all the serological markers is mentioned here. We mentioned earlier, but they will be positive in 50% of non-celiac gluten sensitivity, which make it quite also difficult to differentiate celiac, non-celiac gluten sensitivity. Then more for wheat allergies, more IgE antibodies. Duodenal biopsy, you have to do much classification for your biopsy and see where you classify for celiac disease. For non-celiac, they say MASH 0 to 2. It's still unclear here because it's quite a studied entity. But with allergy but for MASH mostly is used for celiac disease, and for duodenal villi atrophy is present in celiac disease and absent in non-celiac gluten sensitivity, and it is non-specific for wheat allergy. So in conclusion, food allergy is treated primarily by dietary avoidance. It's quite complex to arrive to which food to avoid, but if there's identifiable food that triggers specific allergic GI syndrome, then those foods should be avoided. And then should be aware that not every patient with lactose intolerance will be symptomatic, and gluten-free diet needs a skilled dietitian, multidisciplinary approach. It's always difficult for patients who present with this gluten-related diseases, IBS, to differentiate their symptoms, as they are quite overlapping. Yeah. Thank you very much. Yeah.
Lawrence, thank you very much. For celiac disease and non-celiac gluten sensitivity, you dealt that quite well in a short time, and I like your slides. Just a couple of points on celiac disease for the fellows. I like Lawrence's algorithm in the beginning, where he divided gluten sensitivity into the autoimmune, the allergic, and the non-autoimmune related. His very first slide in green. So put it in your head, yeah, just go up, 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 up. Yes, there. So that's a beautiful slide. I like that. Please remember it. And it's not only celiac disease, it's wheat allergy and the non-celiac gluten sensitivity. Now, the biggest problem that we have nowadays is actually the non-celiac gluten sensitivity. It's been shown that this is almost, and it's been shown that in females, this is almost like a fad. If you go into all the aisles, in all the malls, you get gluten-free diets. And there's some important people that have even said, no wheat, no weight, no wheat, good brains, and all sorts of things. And yet most of us have grown up on wheat. So I think it's a slightly over-exaggerated, and people ascribe all sorts of things, their mood changes, their whatever, to gluten. But I think I like the way Lawrence went through it. Quickly, Lawrence, on celiac, go down on your slides on the MASH classification. So the fellows, please know this picture, you must all look, no, go up again, go up again. Yes, the bottom cartoons, tissue transglutaminase, and in fact, the whole bottom one is actually the deaminated gliadin peptide. And today, the most important test that we should actually do is the IgG DGP, okay, which is from the bottom part. So I like the slide also. Move on, Lawrence. So for the fellows, please, you must know the MASH classification. Move on. And you must know the endoscopic features. So there are four endoscopic features here. So there's the flattening, there's the nodularity, there's scalloping, and of course, the histology, you've gone through it very carefully. In terms of the therapy, as you pointed out, there is a withdrawal, and one has to just follow that. And a small percentage of people do have what we call resistant celiac disease. I must say, we haven't seen this at Baragwanath Hospital. But Chris Mulder, the guy from Amsterdam, has always told us, you guys are missing celiac disease. And he's been to India and all over Africa, and he says he finds celiac disease. I still don't believe him, but I think the non-celiac gluten sensitivity is making a big ugly, because the Australians and Americans have taught us about this. And I think more often, this is what we're going to be confronted with. So again, Lawrence, you dealt with this excellently, and I like your slides. You've had 6 words per line, never more than 6 lines per slide, beautiful cartoons. I like the way you presented. Thank you very much, Lawrence. Before we close off, there's a question from Joseph Adabia. Joseph, unmute yourself and go ahead and ask the question.
Thanks, Lawrence, for such a detailed presentation. I just want to, I know this is quite a broad topic. On celiac disease, do you perhaps want to say a thing or two about celiac and the liver?
Celiac and the liver. Okay. In 2 words, Lawrence.
Well, we mentioned it's multi-systemic, so indeed, celiac can present with deranged transaminitis, which can be quite non-specific. But you can help me, Prof. Yeah.
No, you can look it up, Joseph. That's a good question. Obviously, there's a whole, because it's an immune-mediated disease, so there's a lot of overlap in terms of hepatitis. Is this autoimmune hepatitis? Is this SLE related? So you are absolutely right. But whenever there's investigations on LFTs, particularly look for immune disease mediated things. Okay, I think our hour is up, and I'm going to, Joseph, just go up on the next one. You can tell us exactly what you found more. I'm going to leave this to Professor Masheko, who's going to tell us, Professor Sheshedi, sorry, Masheko, who's going to tell us something about next week's presentation. Thank you, guys, and thank you to India. And please fill in your questionnaire afterwards.
Hi, Prof. Thank you so much. And congrats to our presenter. I agree with Prof. I think you did a fantastic presentation. And I think this topic is one of the topics that's a gap in our curriculum. We teach a lot of celiac, and it comes up almost in every exam. But I think the other aspects like the lactose intolerance and then just the pathophysiology of the food intolerances, I thought you covered really very nicely. And these patients you will see in private practice, having already eliminated stuff that they shouldn't necessarily have eliminated. So thank you so much, Dr. Kwape. I thought that was excellently done. Guys, for me, I just want to make a quick announcement. So the next session, which wasn't scheduled, so this would be an in-between week, is next Monday. And I don't know if some of you are aware of GEEKS Foundation. So that's a gastrointestinal endoscopy quality and safety foundation. I've been on some of their webinars, which are excellent. You can subscribe to the site. I think it's not too costly, especially for fellows. But what Professor Thompson has arranged is for Dr. Tate, who's one of the faculty on GEEKS, to give us a series of lectures. We're going to start with one and see how we go. So next week, he's doing assessment of polyps and what to do. And then we'll try and fit in another session, later on. And then we are negotiating that they can allow us free access to some of the modules that they have. Because of course we're doing a lot of curriculum and stuff, but I think in terms of practical endoscopy, we don't do a lot of that. And even with our fellows meetings and so forth, it's hard to get a hands-on practical session for a group of 20, 30 people. So I hope this will go some way in filling that gap. So please, Karen will send out the invite for next week, Monday. It's not a usual session, but please, guys, if you can, please attend. I think it's going to be quite nice, and it's going to be interactive and so forth. So that's next week. Then after that, just to alert you so that there's no confusion, after that, on the 1st of August, we do have a session. I'm not sure who the fellow is that's presenting. And then on the 8th of August, there's no session because on Tuesday is a public holiday, and we thought that perhaps people might be away for the long weekend, etc. So no session. say, no, the 8th of August. On the 9th is Women's Day, Prof.
Yeah,
There's
no, I mean
session
that
on
week, yeah.
Monday. Yeah. And then the week after that, the 15th of August, is the Monday after Sages. So I thought again that people have been traveling and
They need a break.
Meeting, so they need a bit of a break. So there's no session on the 15th of August either. Now on the 22nd would have been a week where there's no session, but then I thought it's an opportunity to present something. So some of you may be aware of an IBD session. It was a Stellara talk in IBD that was given by Prof. Amutsi. It was hosted by Janssen. I know that some of the fellows were able to attend, but I know that some people struggled to log in on the virtual. It was an excellent talk. He wasn't just talking about Stellara. He actually put the whole of IBD and management and sequencing and all of that in the talk. So Melanie from Janssen, I've asked her to give us the recording, but because of their company policy, etc., she's not actually able to send me the talk so that I could send it to you guys. But she has agreed to actually present the talk as a Zoom meeting, and it's a recording. So I would urge you to please attend. We're going to do IBD module at the end of next year, but this offer is expiring in the next 2 months. So I thought we should take the opportunity to look at this recording. As I say, I thought it was really excellent, and it covered a whole range of sort of IBD issues, not just ustekinumab. So that's a video recording. And of course, the bonus is that you don't have to prepare. You can just pitch up. No one has to prepare a talk.
Excellent.
After that, on the 29th of August, there's no session, and then we will resume our fortnightly session. So that's the talk that Prof. Amutsi gave. So I think that happened on the 25th of May. But as I say, we have a limited amount of time to access it, thanks to Janssen, and I thought it would be nice for you guys. So that's the plan. I hope it makes sense. You please look out for emails from Karen. Don't ignore the ones that are in between the weeks as per original dates. Yeah, I think that's all I have to say. And once again, thanks for a fantastic session. Prof, I'm going to hand over to you to do
no, there's not much to say. Thanks, Prof. Seshedi. Please, was excellent. Yeah, please don't forget to fill out the questionnaire at the end, because that's how Project Echo and INEA can know what they are doing right and not doing right. So thanks to everybody for sitting in on this session. Have a nice evening. Bye-bye.